Ladies and gentlemen, welcome in Bratislava, Slovak Republic. Let me introduce me. I am Petr. I am head of Department of Ophthalmology of Slovak Medical University and Univerzitná Hospital Bratislava. And I have here my colleagues, Dr. Majtánová from the same clinic, Associate Professor Minár from Department of Neurology, and Dr. Janík, it's psychiatrist, and our colleague Dr. Brngál that will present for us 3D dimensions of ophthalmology. So, I would like to welcome you on the first international webinar. It's actually first from our department. The name is Interdisciplinary Challenge. For this reason, we have here not only ophthalmologists, we have another one colleagues, as I said, from neurology and psychiatry. Okay. Let me introduce our first speaker. Our first speaker is Professor Jeseňák. Professor Jeseňák is immunologist, and he will speak about pieces of immunology in mosaic of ophthalmology, helping each other. Please, Professor. Okay, we can start.
Okay. Okay, hello everybody. At first I would like to thank for inviting me. It's a great pleasure to be here, to be part of such nice events. So as it was said, I'm clinical immunologist. I'm taking care about the children and adults with rare diseases. And what is important is that in my praxis, I'm usually using also the help and the need of the other colleagues from the other physicians and from the other specialties. And I was asked to speak a little bit about the possible role and possible contribution of clinical immunologists to the daily practice of ophthalmologists. So therefore, I would like to focus the attention on some immune aspects of ophthalmological diseases and some consequences of the immune reactions and hyperactivity in a case or in means of ophthalmological pathologies. Since I'm clinical immunologist, I'm taking care about the patients which are suffering from some kind of immunopathological disorders. And these are the disorders which are usually the consequence of some disequilibrium in the immune reactivity. Basically, we have two possibilities. Either the immune reactivity is increased and is hyperactive. And therefore, in these cases, we can see the development of allergies. Currently, we know that approximately 1/3 of European population is suffering from some forms of allergy, whatever the most common is allergic rhinitis or allergic rhinoconjunctivitis. On the other hand, we have also the bronchial asthma, food hypersensitivity and drug hypersensitivity. And we can expect that within a few years, approximately half of whole European population will be suffering from some form of allergies. In allergies, the immune system is hyperactive against something which is in general not harmful nor dangerous. And in case of allergic patients, our immune system is considering these non-dangerous aspects like something dangerous and is trying to fight against them. The other possibility is that the immune system is fighting against something which is our own cells, antigens, tissues, and so on. And in these cases, we are speaking about the autoimmunity. In autoimmunity, basically, now we have approximately 7 to 8% of whole European population suffering from some form of autoimmunity. And also eye and eye tissues can be affected by certain forms of autoimmune diseases. Either which are isolated to the eye, but on the other hand, we have a broad spectrum of systemic autoimmune diseases, which is also the eye complication and eye manifestation. The last and the third group of hyperactivity immune disorders are called autoinflammatory diseases. These are maybe the newest form of hyperactivity immune reactions. And in these cases, there is a strong dysregulation of innate immunity and hyperactivity of the inflammatory cascade. And we have very interesting group of rare diseases which are affecting, besides all the other organ systems, also the eyes, and I will be speaking later on about them. The other possibility is that some part of the immune system is missing, is not working efficiently, or is defective. In these cases, we are speaking about the immunodeficiencies. Up to now, we have approximately 50 different forms of primary immunodeficiencies, but I should say that in the clinical practice, usually we are seeing the patients with secondary immunodeficiencies, which are more common. And also the tumors and oncological diseases are currently considered to be the result of insufficient immune system overview or surveillance over the tissue proliferation and the cell proliferation. Tumors also are affecting ophthalmological area or eye tissues, but I would like to speak more about tumors since the tumors are not in the head of clinical immunologists. So basically, in my next few minutes, I will be focusing on the allergies, and I will spend a few words also about the autoinflammatory diseases, since this is my primary area in which I'm working. We have several common problems with ophthalmology, and usually I'm asking my colleagues from ophthalmology department just to help, especially in case of some severe complication of allergic ocular symptoms. So we can have allergic conjunctivitis or isolated forms of different allergic diseases of conjunctiva, like allergic conjunctivitis and so on. Then we have atopic eczema with involvement of periorbital area and contact dermatitis, which can be the consequence of, for example, applied cosmeticals, of applied of makeup, but also of certain medicaments which can be connected with contact dermatitis. Atopic dermatitis of ocular area can be isolated or is a part of complex presentation of atopic eczema in the patients. We have a broad spectrum of autoimmune diseases, either the diseases which are affecting in isolation only the ocular tissue, like uveitis and episcleritis, but on the other hand, this can be also the consequence and the clinical symptoms of different systemic connective tissue diseases. The problematics of dry eyes is very complex and is affecting, besides ophthalmology, especially rheumatology and some other immunological areas of medicine. Then we have a very interesting group of autoinflammatory diseases, which are sometimes called periodic fever syndromes, which are connected with some mutation in the genes which are trying to regulate the inflammatory cascade. In this case, due to the pathological mutation, this patient have the loss of the control over the inflammation. And some of these diseases have also the ocular manifestation. I will be speaking later a bit about them. And then, of course, we can have some side effects of topical or systemic treatment, which is used, for example, in allergic diseases, but also in autoimmune diseases, which can have the consequences on the eye tissues, like the use of systemic corticosteroids. Currently, we are just trying to avoid the long-term use of corticosteroids, for example, for treatment of asthma and bronchial asthma and atopic eczema, since currently there is a strong recommendation to use different forms of biological therapy instead of systemic corticosteroids, which can have a lot of systemic side effects. We are using colchicine in familiar Mediterranean fever, which is one form of autoinflammatory disease. It can have also the eye complication. And for example, in hereditary angioedema, which can have, for example, the symptoms of angioedema of the eyelids, we are using for long-term prophylaxis androgens. And therefore, this patient should be regularly checked by ophthalmologists just to prevent and early detect the eye complication of such systemic treatment of immune-mediated diseases. What about affection of 4 layers of ocular tissue? I don't want to go into deep, since all of you are very familiar with all of this classification and division into 4 tissues. But basically, in anterior portion, we have the tear fluid layer, which is very interesting from point of view of immunology, since we know that in tears there is a high concentration of immunoglobulin A. There are some enzymes and some other protective factors which are trying to defend the eyes against the invasion of bacteria and viruses. Usually, conjunctiva is considered to be the eye primary barrier, and conjunctiva can be frequently affected by allergic diseases. Second part of the tissue is collagenous sclera, which is typically affected in different connective tissue diseases, for example, in systemic lupus, in Sjögren's syndrome, and so on. uvea is usually part of inflammatory reactions which are connected with circulating immune complexes with the activation of complement system and prolonged inflammation. And then, of course, we have retina, which is in some ways extension of the central nervous system. From immunological point of view, eye is very unique because it doesn't have the form lymph nodes, which is maybe the only organ without the lymph nodes. And typical the lymphocytes, which are very important part of specific immunity, can be found either in lacrimal gland and also in conjunctiva. Under certain conditions, different immune cells are proliferating in conjunctiva and are affecting this tissue with chronic inflammation. Each part of the eyes can be affected by different immunopathologies. I will be speaking a little bit about the allergic symptoms like allergic conjunctivitis, vernal conjunctivitis, and some other more severe forms of allergic diseases of the ocular tissue. Then in the lids, we can usually on the lids see the contact dermatitis and also the symptoms of atopic eczema. We know that this is very risky area regarding the application of different topical medicaments such as corticosteroids and so on. So therefore, in this area, we are usually trying to use the topical application of immunomodulators like pimecrolimus or tacrolimus. In cornea, there is very interesting from my side that in chronic autoinflammatory diseases, we can see the deposition of amyloid. Amyloid is the acute phase reactant, which is usually increased in different forms of autoinflammatory disease. And then all the other pathologies you can see on the slide. I will be speaking a little bit about the allergies, and then I will be focusing on autoinflammatory diseases. Few words to the allergy disease. Today we know that allergic disease of the eyes are affecting approximately 10 to 20% people globally, which is very typical in differential diagnosis that allergic symptoms are usually bilateral. The most common dominant symptom is itching together with the redness and watering of the eyes. And it can be connected, but also can be isolated with rhinitis. In my practice, I see a lot of people with only allergic rhinitis, but approximately 1/3 of this patient is suffering also from the clinical symptoms from the conjunctiva. In allergic conjunctivitis, which is the most common form of allergic disease of the conjunctiva of the eyes, this is considered to be the muscle disorder. So it means that the muscles are proliferated and they are overacting because on their surface there is a high amount of specific IgE which are binded to their surface receptor. And in case of allergen provocation and exposure, it comes to the degranulation of the muscles and clinical symptoms of allergic conjunctivitis. All the other more severe forms of allergic disease of the eyes, like vernal keratoconjunctivitis, giant papillary conjunctivitis, which is usually connected with contact lenses, these are considered to be the reasons of proliferation and hyperactivity of the T lymphocytes. Regarding the treatment, of course, we can use topical antihistamines, we can use topical muscle stabilizers or combined medication, chromones, and in certain severe cases, we can use also the immunomodulators, tacrolimus and cyclosporine. For example, in Slovakia, and these are different differences from the other countries, some of these topical application can be prescribed only by ophthalmologists, so I am not allowed as clinical immunologist to prescribe the cyclosporine for very severe forms of vernal conjunctivitis. And now I'm coming to the core of my presentation, and this is the group of autoinflammatory diseases. I'm very pleased that I can speak about this very specific form of primary immunodeficiencies because there is increasing awareness about these diseases all over the world. This is usually in the focus of rheumatology and immunology. What is very interesting in autoinflammatory diseases is that there is an involvement of innate, non-specific immunity and its dysregulation, and it comes to the spontaneous activation of inflammatory cascade. But currently, we have a lot of different immune complicated mechanisms, how the inflammation can be provoked without any triggering factors. The most famous are inflammasomopathies. Inflammasome is a multimolecular structure which is in the cytoplasm of neutrophils, macrophages, and so on. And in case that this structure is activated, it leads to the hyperproduction of different pro-inflammatory cytokines, especially interleukin-1 beta. These diseases are very similar to rheumatic disorders, but usually we are missing both of autoantibodies. And the most common long-term complication of this disease is amyloidosis, and this can affect also the eye tissue and lead to the cataract. What are the clinical symptoms of autoinflammatory diseases? We have some common characteristics like recurrent flares of inflammation, which can be connected with fever, but it's not absolutely necessary. Very typical, these patients have psoriasis, different skin symptoms like rash, urticaria, symptoms very similar to erythema nodosum. And what is typical for this patient that each flare of fever and inflammation is absolutely uniform. So the patient has usually the same duration, like several days, has usually the same clinical symptoms, involvement of the same organs and tissues. During the acute flare of anti-inflammatory disease, you can see the elevation of acute phase reactants. Usually we see the absence of autoantibodies and the long-term complication in case of very delayed diagnosis is organ amyloidosis. So let's have a look on the most common forms of anti-inflammatory diseases, which are maybe the most famous. The worldwide most famous is familial Mediterranean fever, which is very typical affecting the people around the Mediterranean Sea, but also in the Israel, in Armenia, and so on. And this is the periodic fever syndrome, which is the longest known all over the world. We have then syndrome which is called TRAPS of TNF-alpha receptor associated periodic fever syndromes. In this case, the patients have fever for longer than 2 weeks. Then we have hyper IgD syndrome, which is typical for the northern part of Europe. The appropriate name is mevalonate kinase deficiency. Then we have very interesting group of cryoperinopathies, which has ophthalmological complication, and the Blau syndrome, which is considered to be the monogenic early juvenile form of sarcoidosis. What about the clinical symptoms? And also in our hospital, I'm just collaborating with our ophthalmologist in case of regular examination of this patient, because we had the National Center for Periodic Fever Syndromes in our hospital. We have approximately 80 patients with FMF, 2 patients with TRAPS, 3 patients with mevalonate kinase deficiency, and 5 patients with cryoperinopathies, and 2 patients with Blau syndrome. So we have quite good experiences. And as you see, very typical in this case is there is a recurrent episcleritis on posterior scleritis. Then very typical for cryoperinopathies in conjunctivitis during the acute febrile flare. In certain cases, you can see the granulomatous uveitis, for example, in Blau syndrome. Currently, we have 2 siblings with this very rare syndrome, which has very severe curves and also very strong ophthalmological complications. So for ophthalmologists, it's important that in case that you see the patients, for example, with recurrent episcleritis, with some unusual and uncommon forms of conjunctivitis, in case that the patient has also the recurrent fever, it can have some of these diseases. And it's quite natural that the last part of my presentation will be focused on maybe the most commonly named disease all over the world currently during the last few months. And this is the COVID-19, because it has also very interesting aspects from the ophthalmological point of view. As probably all of you know, this new infectious worldwide pandemic is called COVID-19 and is caused severe acute respiratory syndrome, virus type Y type 2, which has the abbreviation SARS-CoV-2. It's highly contagious infectious diseases, and in the past we have some other previous pandemics, which was SARS-CoV-1 and MERS. Comparing the mortality, the SARS-CoV-1 and MERS had higher mortality compared to SARS-CoV-2. It spread through the droplets by inhalation into respiratory tract, but very interesting for ophthalmologists is that in case that these droplets are in contact with conjunctiva, this is another possibility how this disease can be spread, and therefore the ophthalmologist during the examination of the acute ill patient should protect themselves by personal protective equipment. In several cases, several aspects, this new pandemic is different from the other forms of respiratory viral infections. And very interesting is that in children, usually they have mild or asymptomatic course, which is in contrast with all the patients and all the people. Very interesting are the risk factors for COVID-19. Currently, a lot of studies have been published, and therefore we know that the mostly affected are older patients, those who are smoking, male gender. There are several explanations why the males are more affected. One of these is that the males are expressing higher amount of ACE2 receptor, which is typical receptor for COVID-19. There can be some genetic susceptibility regarding the complicated course of COVID-19. Very typically across all these studies, you can see quite high numbers of the comorbid patients, like those who are suffering from hypertension, ischemic heart disease, obesity, and diabetes mellitus. What is interesting from my point of view is that there is very low proportion of the asthmatics. From the chronic respiratory diseases, the patients with chronic obstructive pulmonary diseases are a little bit more risky. But in general, you see that the chronic bronchial asthma and some other typical diseases for respiratory viruses are not risk factors for COVID-19. There are three important pillars of success for this virus, but that it spreads so quickly. It has very high infectivity because the patients are able to spread the virus before the clinical onset of the symptoms. As you see, the longer the incubation period, which can be up to 14 days, usually it's 5 to 7 days. So therefore, in case that the patient has the symptoms on, for example, 14th day, it can spread the virus like 10 to 14 days without any symptoms. Therefore, it's very high contagious. What about the ophthalmological complication of COVID-19? The number of the publication is also increasing. When I did some very similar presentation like 3 months ago at the beginning of the world pandemic of COVID-19, there were only few case reports, but currently the number of the publication with ophthalmological complication of COVID-19 is increasing. What was very important is that one of the first clinical symptoms of COVID-19 can be mild follicular conjunctivitis together with tearing. So in case that you see the patient with cold, fever, and conjunctivitis, you can think about the possibility of COVID-19, and therefore you have to protect yourself by wearing the personal protective equipment. Although I know it's quite complicated, especially if you perform some very specific ophthalmological examination. As I've told you before, COVID-19 is spread also by aerosol contact through conjunctiva. And very interesting is that approximately 1/3 of the COVID-19 patients can have some eye-related symptoms. And what is interesting, up to now, no ophthalmological complication were reported in the literature. Regarding chronic treatment, for example, which is applied by yourself, for example, by biologicals and so on, currently there is a strong recommendation that all the patients which are taking some chronic immunosuppression and chronic biological therapy should continue in this treatment. In case that there is a possibility to prolong the interval, you can also do that. But in general, it's absolutely not recommended to stop some of the chronic long-term treatment, because in each chronic disease, the best prevention against the COVID-19 complicated course is to maintain the control over the chronic treatment disease. From my point of view, it's very important and interesting to be able to discriminate between certain other diseases which can have very clinical similar course, like allergic rhinitis, rhinoconjunctivitis, common cold, flu, and COVID-19. So I'll be focusing on this disease a little bit. What is important and interesting is that during the global warming of the climate, the season or pollen season for particular allergens is increasing and enlarging. And as you see, if you are a polysensitized patient, you can see that the pollens can be presented during the whole year. Since early January, you can see, for example, the alder and the walnut and so on, which is later on replaced by the birch, which is typical allergen for the Central and Northern Europe. Then approximately in the middle of Europe, you can see the start of the grass pollen season. in the middle of May, but if you go to the southern parts of the Europe, it's much more earlier. So at the beginning of the April, you can see the pollens of the grasses in the air. And then later on, there are some wheat, like a very typical ragweed, but also mugwort and so on. This is very important in case that you have the patients with like recurrent symptoms each year in the particular season, which is connected with particular pollen. Very short comparison between these four entities. For you, it's very interesting that the clinical symptoms from the upper airways are not such common in COVID, for example, compared to flu. Allergic rhinitis, of course, there is no fever. There can be sometimes the headache, which is the consequence of the obturated paranasal sinuses. Myalgias, fatigue, and so on is absolutely rare in case of allergic rhinitis and rhinoconjunctivitis. On the other hand, in COVID-19, the extreme exhaustion is progressive. In flu, this is very early sign. And also in these two cases, like flu and COVID-19, you can see the diarrhea and gastrointestinal symptoms. Regarding the respiratory symptoms, you see that nasal congestion is very typical connected with allergic rhinitis. And one of the most discussed clinical symptoms currently is the loss of smell and taste, which are the early symptom of COVID-19, and they are typically more frequent in females compared to males. Cough is very typical for COVID, but also for flu. For flu is not such common. And in dyspnea, this is very rare for flu, but very typical for COVID-19. Allergic rhinitis, dyspnea can be the symptoms of nasobronchial hyperactivity or of associated bronchial asthma. So just two nice pictures. On the left, you can see the flu, and on the right, you can see the virus 19. So what can be said at the end of my lecture? The first thing is the COVID-19 affected all the people, and I should say that all the physicians and specialists were connected by this diagnosis. For you, it's important that it can be transmitted also by conjunctiva, and 1/3 of the patients can have the eye-related symptoms. Usually, the first sign of COVID-19 can be the follicular conjunctivitis together with increased tearing. Of course, in each patient which is suffering from some chronic diseases, whatever it is, whether this is disease of the eyes or this is the systemic disease, it's absolutely important to have some individualized approach and to continue in the treatment. And when the ophthalmologist can ask help of the immunologist, of course, if you have the patient with ocular allergies, we can help you with the diagnosis of causal allergen. We can perform the skin testing and laboratory testing, and of course, we can start allergen immunotherapy, which is the only causal treatment of the allergies of the eyes and of the respiratory tract. Then, in case of drug hypersensitivity, whether this is the symptom of systemic application of medicaments, but also in topical application, for example, in the ophthalmological application. In certain cases, if you have suspicious for immunodeficiency due, for example, recurrent, very severe infectious diseases, for example, of the lacrimal gland and so on, we can help you with the evaluation of the immune status, and we can also make some proposal for immune support and immune substitution. In autoinflammation, this is an interesting group of new diseases which are genetically inherited. Just please remember about the Blau syndrome, about the familiar Mediterranean fever, which can also affect the ophthalmological tissue. And of course, we have some other complex syndromes which can have also ocular manifestation, and we can help you by evaluation of, for example, immune system and all the other aspects of these diseases. And I can say that, of course, regarding my practice, in whatever other occasion, we are absolutely fully for your disposal, and we really love to collaborate also with the other specialists and other colleagues. And in certain cases, for example, of severe ocular allergies, we are not able to prescribe some of the medicaments, and you can help us. So I will kind of finish with with the photograph of my popular part of the world, which is the stromboli. And once again, thank you for the invitation. I'm open for discussion. Thank you.
Thank you very much, Professor Jeseňák, for your very lovely talk. I'm very proud to know one of the youngest professors in Slovakia. Please, I would like to ask you to put your webcam on so that everybody can look at you and see you. Now I will just say a few words about the connection of allergic conjunctivitis with your medications. Of course, it's one of the most common conditions encountered by allergists and also ophthalmologists. The good cooperation leads to well-treated and a satisfied patient, which is most important for all of us, of course. We have many types of allergic conjunctivitis. All of the ophthalmologists are well known with all of these types. What we should do in a diagnostic workup is to know the history of allergic disease, the seasonal history, of course, the wear of contact lenses, and the family history of atopy. The symptoms are very common. It is redness, burning sensation in the eye, various itching processes, watery discharge, and mild photophobia. When we examine the patient, we can find hyperemia and chemosis, a mild papillary reaction, and edema of the eyelids, papilla, and follices. Of course, we should perform a conjunctival scrape to detect eosinophils, and we can also send the patient for allergy skin prick test. It is very common to measure inflammatory mediators in tear levels, of course, if we can have this kind of measurement in order to detect IgE and histamine. Of course, the most important management in all of these cases is to avoid exposure to allergens, and then we should minimize them in the most possible way. The patient can use also cold compresses and topical tear substitutes to flush out the allergens. The therapy is various. Of course, we should try various therapies on various patients because it's not a rule that one therapy is the best. Each patient can need different combinations of therapy. Also, of course, we need your help, and we need to use also oral antihistamine therapy, which is prescribed by you. The take-home message for me is that allergic conjunctivitis is one of the most common inflammatory diseases of the eye. Of course, we still have many unanswered questions about the role of phenotypes, genotypes in this disease heterogeneity, the role of various types of allergens in vernal and atopic keratoconjunctivitis, or specific mediator and cellular mechanisms associated with particular types of ocular allergy. So it is very necessary to identify new diagnostic tools and novel therapies, especially to control symptoms in severe patients. Professor, I would like to ask you now whether do you use cyclosporine in very complicated patients? And what are your experience, local cyclosporine, of course, with the combination, of course, of an ophthalmologist, not by yourself?
Unfortunately, I cannot use directly cyclosporine. Every time I should ask our colleagues from ophthalmology department to prescribe these medicaments, since I'm not allowed as a specialist to prescribe this. But on the other hand, we have few numbers of the patients with very severe, especially the vernal keratoconjunctivitis, in which we were not successful with combined therapy with local antihistamines, chromones, and systemic antihistamines. In these cases, we have, as I remember, good approximately 3 to 4 patients which are treated by cyclosporine in topical application. Of course, you should regularly check the patients, and it should be under very strict surveillance by the ophthalmology. But we have certain combination. On the other hand, I just want to remind you that also intranasal corticosteroids can have positive effects on the allergic conjunctivitis.
Yeah, but then we have to very carefully monitor the patient and measure the levels of the intraocular pressure, because when he has the corticosteroid therapy, the eye pressure can increase, and then we can have a severe problem. We have a few patients also who have a severe allergic conjunctivitis, and we usually prepare them with a local cyclosporine for a period about 2 to 3 months before the season, and we really have very good results with this kind of patients. This is our experience from our clinic. So I would just encourage everybody to try the use of cyclosporine locally, especially in the severe cases. And I have another question. You mentioned COVID-19. It's a nightmare for all of us, of course, and I would like to ask you whether you think that we will have a second attack of COVID-19. What's your opinion?
Well, this is the most common question I usually had from the other specialties. I don't think that we will have the classical second wave of pandemic. Okay, we will have some imported cases, but I wouldn't expect any very severe second wave of COVID-19. Maybe a few words what is interesting from the point of immunology. This is very strange virus regarding the immune response, because usually according to the logic, at first you should have the positivity of IgM antibodies, which are followed by the positivity of IgG. But on the other hand, we have certain patients in which the IgG is before the IgM. So there is very complicated interpretation of the laboratory results. And what is expected is that there can be some cross-reactivity with the other forms of the coronaviruses, which are very common. And therefore, some of the positivities of the laboratory testing can have the false positivity. For example, in small children, one of the explanations why the children are not so strongly affected by COVID-19 is that because they have very high number of respiratory infections and they have a lot of coronaviruses on the surface of the airways. They are a little bit partially protected against this novel coronavirus. But just to summarize, I'm quite optimistic immunologist. I don't expect the second wave of COVID-19.
Thank you very much for your presentation, and best regards to University Hospital in Martin, and I hope that we will meet each other in another international webinar. Thanks again. And now it will
Thank you very much.
Bye-bye. Now it will be a pleasure for me also to listen to the other speech of Associate Professor Minár from University Hospital in Bratislava. And his presentation is called Eye Pain, Headache, and Migraine. What is the relation? Many of us have often headaches, eye migraines, so I hope you'll explain why.
I will try. Thank you for introduction, nice introduction. Thank you for invitation here for this webinar. It's really important to make all these types of interdisciplinary actions, so I will hope to tell you something more from the neurological point of view. I will speak about the connection between the eye and the brain, the connection between neurologists and ophthalmologists. And as we can see here, there are a lot of conditions which are presented both with the pain and with some visual disturbances. It's a lot, but since it's Friday, I will not speak about all of them. I will speak only about the most important or most common that we can meet in everyday practice. Speaking about the pain, it could be really localized strictly in the eyeball, or it could be spreaded more around the eye or on the half of the head, but always touching the eye or being in connection with the eye. And speaking about the visual signs, they could be both positive and negative. Positive means that patients see some rainbow, some lightnings, flashes, some colors, or could be negative, which means some disturbances in the visual field, from small scotomas, from blind spot to loss of half of visual field in hemianopsia, or total blindness of one or both eyes. And these symptoms or these signs of visual disturbances can originate both in the eyeball or in the retina or in the CNS in the optic pathway. Then you have the patient which is not aware about this etiology and pathophysiology of these symptoms. So I have some pain of the eye, I have some headache, I have some visual disturbances. Which doctor should I see? So it's really up to the patient which specialist would be seen the first. Maybe it depends on the proximity of the doctor or availability, but all of us or both of us, ophthalmologists and neurologists, can see patients like this with these overlapping conditions. This is the last or recent third international classification of headache disorders, and when we look at it, it has three main parts: primary headaches, secondary headaches, and neuropathies connected with cranial nerves. In all these subtypes or all these divisions, we can find some patient with overlapping conditions of eye and brain problems. Speaking about the primary, it's migraine and cluster headache as a part of trigeminal autonomic cephalgias. In the secondary headaches, it's anything what is connected with vascular disease of the head or of the eye or disorders of eyes themselves. And in the cranial nerves or in the neuropathies, it's painful optical neuropathy. Let's start with the last one, because I think this is the typical diagnosis where a patient could find both ophthalmologist and neurologist. Don't be scared with this list. I just want to show you that somewhere there is a really painful optic neuritis in this amazing list of all possible neuropathies leading to the pain of eye or pain of head. And optic neuritis is inflammation, usually unilateral, of the optic nerve. Patient usually complain about the blurred vision, about some eye pain, which is not frequently spontaneous. It's usually connected with the eye movements or pressure on the eyeball, but the pain could be severe. So again, it's up to the patient where to go, which specialist to find. It's typical disorder of young patients from 20 to 40 years of the age, and women are more affected than men. Even though we start treatment or fast treatment with steroids, there are some 50% of patients that can develop irreversible visual loss, so it's really alarming, especially because it's the productive people, young people, which really need to have 100% of vision. So this is big question for ophthalmologists to start treatment early, but what is alarming for me as a neurologist is that optic neuritis could be the first attack of multiple sclerosis, or it could be a clinical isolated syndrome. And even though the patient is with no other signs, and even though the MRI is negative, 1/5 of the patient can develop fully expressed relapse remitting multiple sclerosis. In the case that MRI is positive, it's even almost 90%. So this is what is alarming for us, that patients should start early treatment or treatment as soon as possible, so because this is the only way that we can slow down the progression rate and disability of the patient. So we cannot wait for another attack, or we cannot wait for MRI positivity to start the treatment, because it could be too late and there could be already some irreversible damage to the brain. What is important, speaking about MRI, is that we cannot omit or neglect the MRI of the spinal cord, because we can have a patient with Devic disease or optic neuromyelitis, which is demyelination, but only of the optic nerve and spinal cord. So we can have clear MRI and say that patient is okay with no SM, but it could be this type of demyelination. This is another terrifying list, but this is a list of the secondary headaches or facial pains due to disorders of any organ on the body, and there somewhere in the middle is headache attributed to disorders of the eyes. So any part of the eye could be affected, and any part of the eye can be affected with inflammation. So we can have 15 itis in the eye, so everything what is inflamed can be painful. And since the nociceptive field overlap and converge in the brain, any ocular pain can spread or can irritate or could lead to headache in any region. So even if it's eye problem, the pain can be felt on the vertex of the head, can be felt parietal temporal, so it doesn't mean that it must be strictly periorbital. But what is typical when the pain is, or when the affection of the eye is unilateral, the pain is unilateral and is 99% ipsilateral on the same side as the eye disorder. Headache attributed to refractive error is well known. It's not that frequent in elderly, because usually patients complain about, we know patients that are almost blind but not complaining about bad vision, but usually it's more typical for children. But we have adult patients that can complain about the headache, and it's due to refractory error. It's impaired in the distance or angle where the vision is worse, and it always improves when the visual task is discontinued, and totally resolves or improves when the refractive error is corrected by the ophthalmologist or the optician. What is more important or more dangerous is acute angle closure glaucoma, which is one of the ophthalmologic emergencies. Generally, it causes eye or periorbital pain. There is a loss of visual acuity. Patient complain about the blurring of the vision. There could be conjunctival injection and edema of the eye, and could be accompanied by nausea and vomiting. What is typical? This increased intraocular pressure increased the risk of the permanent visual loss. So it's really emergent situation, and the early diagnosis is essential. And again, the early treatment is the most important thing to save patients' vision. On the other hand, open-angle glaucoma is painless and slowly progressive, but is not less dangerous because the result, the visual loss, could be the same. But thank to God, it's painless and slow progressing. And what is important to mention is not really well-known diagnosis, especially among neurologists. I can say for me. It's a form of open-angle glaucoma, and patient had the same finding on the ophthalmology and the same pathological changes, but usually the intraocular pressure is in the range of normal values, so the patient is not like treated if this diagnosis is not taken into consideration. So this is important thing to think about also this. All these eye disorders are really in the hands of ophthalmologists, both diagnosis and treatment. But again, this patient can come first to us, to neurologists, so we need to be aware of these conditions to not treat, but in good way send the patient to ophthalmologist to be treated or diagnosed and treated. Now I will speak only or especially about the neurological diagnosis. From primary headaches, it's migraine and cluster headache. Migraine is considered to be third most prevalent disorder in the world. Can be true. And it's third highest cause of disability worldwide in both males and females under the age of 50 years. So again, it's a disorder or disease of people in productive age which need to be at work every day and not spend 3 days in the bed. Women are more affected than men. And typical combination of symptoms are severe headache and some visual signs. What is typical from migraine attack? That it lasts some hours, from 4 to 72, for sure if it's untreated or unsuccessfully treated. It's unilateral pain, pulsating, patient describe it as moderate or severe in intensity, and it's aggravated by routine physical activity. So typical patient with migraine is not moving, can be with some nausea and vomiting, and can be sensitive to strong light and strong sound. So really this patient is like vampire in the dark, in the silence, laying down like in the coffin and not moving and waiting for some rescue or waiting for attack to resolve by itself. What is typical for migraine? That some patient can have some symptoms which precede the headache, and the name is aura of these signs. And it's unilateral, fully reversible combination of this visual, sensory, speech, motor, brainstem, or retinal symptoms. What is typical? They should be, or they are accompanied or followed within 60 minutes by the typical migraine headache. These symptoms can be isolated, but usually they come like in the chain, starting with the visual aura, then continuing to the limb, like some numbness, needles feelings, and then can be followed by speech problems, problems with articulation, or even aphasia. This is what could visual aura looks like. You can really experience any type of flashing, lightning, colors, but what is really typical is this fortification spectra, or these zigzag rainbow lines. Many patients complain really about this. They see it in right or left half of the visual field, and then they are followed by the headache. Diagnosis is again in the hands of the neurologist. When we have typical all criteria fulfilling headache of migraine, we don't need any specific test. We have diagnosis already. If we have some insecurity about some atypical signs, we can perform brain MRI, but it's not necessary. But I think every patient deserves MRI with the angiography, and treatment in mild cases with painkillers, in severe cases with triptans. And if the attacks are really frequent, we can use prophylactic therapy on everyday basis, and we can use antidepressants, beta blockers, anti-epileptic drugs, or injection of botulinum toxin to pericranial muscles. Similar distribution like hemicrania is a cluster, but compared to migraine, it's more strictly periorbital. It's usually more severe than migraine, but thank to God it's shorter, lasting minutes, not hours. It occurs from once every other day to 8 times a day. So patient can have 8 attacks a day. These days could be like in the cluster, that's why the name, like few days after each other. And then the patient is some weeks, months, or even years without any symptoms. So this is the name cluster because the attacks come in the clusters. Compared to migraine, it's more predominant in men patients, and again, it's a disease of young people. This headache is accompanied with these signs with conjunctival injection, nasal congestion, and rhinorrhea, eyelid edema, forehead and facial sweating, could be miosis and ptosis. So this patient can look like or can resemble patient with acute glaucoma. So that's why this patient can go both to neurologist or to ophthalmologist again. Both mentions migraine and cluster headache, or all primary headaches, are disorders of young people. Its prevalence really decreases with the age. So when we have patient more than 60 years old with new onset with acute headache, it's usually secondary headache. And for the really old people, about 60, 70, 80, first thing we need to take into consideration when we see patient with headache imitating migraine, so unilateral, pulsating, and severe. It could be giant cell or temporal arthritis. It's again immune-mediated disease, but headache is really typical for migraine. It's really like this. What is difference? Patient can have some other signs like neurological signs. Compared to migraine, you have no phosphens, you have more scotomas or blindness, so there is a loss of vision. And this is the important thing. When we want to save this vision of this patient, we need to start again steroid treatment immediately. What other signs that can help us is fever and elevated acute phase indicators, but usually this patient don't have these signs, all of them, because they could be really old and don't need to have these signs. But if they have, it can help us with this diagnosis. Speaking about the veins or with the vessels, there are patients with cavernous sinus thrombosis. It's not that frequent. I saw maybe one in my long career, but it could be really severe headache. It's often accompanied by tearing, by swelling of the eye, redness, irritation. So again, something that can look like cluster headache or glaucoma. There could be vision loss, there could be double vision since all oculomotor nerves go or pass through cavernous sinus, so there can be more diagnoses, more signs in this diagnosis, and the patient need to go for ideally CT or CT scan with the angiography to confirm this. I just continue with this vessel disease. So patient with any type of expansive condition in the brain will have a headache. It's typical for all type of intracranial hemorrhage, going from left to the right, intracerebral hematoma or hemorrhage, subdural or epidural, all can be with a headache, and if they're localized in the optic pathway, you will have some visual disturbances. Speaking about intracranial tumors, they are slowly progressing, so you can have some slow worsening headache, speaking about weeks or months. And if they again affect some part of the optic pathway, they can lead to visual disturbances. What is typical, for example, bitemporal hemianopsia would lead us to think or consider pituitary adenoma. But we can speak about a lot of brain tumors, bleeding, some infection disease, but really it's Friday, so I will stop here. What is important to take from here for the weekend is the most common diagnosis, which really have overlap of the pain and visual symptoms, and they are all here. It's optic neuritis, typical migraine with aura, cluster headache, temporal arteritis, and acute glaucoma, which have typical patients or typical young of onset. They have really typical signs, but nothing is typical, nothing is 100% in medicine and not even in neurology. So we can be really confused with the patients, and this patient can come both to neurologists and ophthalmologists. So all of us or both of us need to know everything about this. So I think this was the take-home message of this webinar, and I hope you will remember the most important things. Thank you very much.
Thank you very much for a very interesting presentation. It is very important to have a friend who is a neurologist But I will try to tell you now my point of view and try to persuade you why it is very also important to have a friend and ophthalmologist from the other point of view. So of course you told us everything about headache. Sometimes it's also associated with ophthalmic symptoms, which are double vision, blurred vision, photophobia, redness, visual aura. Of course, you mentioned all these types of headache. I'll just stop here near the ophthalmic causes of headache. It's the refractive error. The patient can have a mild frontal headache. It can be worse when he has a prolonged visual task, when he works for a longer time on the computer. Of course, it can be also a kind of heterophoria or heterotropia, with mild frontal headache, intermittent blur, or double vision. You also examine patients for this cause. Of course, it can be also associated with herpes zoster ophthalmicus, with pain, hyperstasia, rash, vesicles, and we can also sometimes see, sometimes not, ocular inflammation. And of course, the most typical type of headache, which is most dangerous, is in glaucoma patients. It can be an ocular hypertension or open-angle glaucoma. It can be a low-tension headache. Also, the normotensive glaucoma can be associated with migraine. If the patient has an angle closure glaucoma, he has severe eye pain around the eye, he has halos, he has loss of vision, and redness of the eye. And then we have a syndrome which is called pigment dispersion syndrome. Here he can have intermittent blurred vision, halos, and eye pain after especially the change of the position of the body, so after exercise or after pupil dilatation, so it means when there's the change of the brightness in the room or when it gets evening and the night. The most important for me as a take-home message is migraine and normotensive glaucoma. Many studies suggested an association between migraines and normotensive glaucoma. Migraines are a big risk factor for normotensive glaucoma progression. There was a treatment study which was done. It was called the low pressure glaucoma treatment studies, and it was reported that this is a predicting factor of optic disc hemorrhage in normotensive glaucoma, and because they're related to temporary vasospasm that leads to the disruption of autoregulation and cerebral blood flow. So it is caused by ischemic phenomena, including microinfarctions in the optic nerve head and optic disc hemorrhage. So it is very important if a patient has migraines also to send him to an ophthalmologist, because it can be an important indicator of microvascular dysregulation, which is related to this type of glaucoma. Of course, you also mentioned sclerosis multiplex. Many times the patients who have sclerosis multiplex, the first doctor they come and see is an ophthalmologist, and we can have the typical criteria that you already mentioned. So for me to remember for home is that headaches are one of the most common medical complaints. There are many ophthalmic causes of headache. Every patient with headache should be examined by a neurologist and also an ophthalmologist. The common ways of treating headaches are rest and pain relief medication, of course, for the beginning, until we diagnose the disease, for example, glaucoma. Several alternative forms of treatment for headaches are also available, but research has not provided evidence to confirm that they work. So we like based medicine, so it's very good to also see an ophthalmologist and a neurologist and to have a common solution to know what's the disease and why the patient is coming to our hospital or to our department. I have one question here on our chat. I would like to encourage you to send questions to our chat if you're interested in some. And the doctor is asking, whether is it good to treat a visual aura that lasts for 30 minutes, 1 to 2 times a week, but without any pain?
I don't know if I don't understand the question, if it's good to treat it in general or with triptans?
With treatment.
With treatment, so it's aura without
pain, and it lasts 30 minutes, twice a week.
So there is a question if it's really aura. if it's typical aura, like with the zigzag picture, so it's not supposed to be like a transient ischemic attack when it's aura. I think without pain, it's useless to use painkillers, but it could be risk for oligemia or ischemia of the brain. So I think these patients are indicated for triptans.
Okay, thank
because
you.
they can stop this at the beginning and don't lead to any complication.
Okay. Thank you very much for your wonderful presentation. And I think that it's time for us to move to the other presentation. I would like to introduce Dr. Janík. Dr. Janík is a psychiatrist. Of course, it is said that many people, because of the lifestyle we are leading nowadays, are patients of a psychiatrist. So I'm still not your patient, and I hope I will never be, but I never know. So try to tell me something about the mind-eye connection, please.
Okay, so hello to everyone. My name is Petr and I'm working as a psychiatrist for outpatients, and I chose the theme mind-eye connection. This is more of a philosophical theme, but I will try to be rather more practical. So when I started to work as a psychiatrist, I found out that there are lots of gaps or black gaps in the etiology and diagnostics of mental disorders. And the more that I work, the more gaps I found. So we have limited diagnostic possibilities as the symptoms are overlapping, as they're mixed, and they doesn't fit to any box. So we have to deal with a clinical picture with a context curves and exclusion of other disorders, especially organic. So another major problem in psychiatry, usually connected with psychosis, is that patients are trying to dissimulate the symptoms. So they're trying to act like they're pretty normal. They doesn't have any hallucinations, delusions. They doesn't know why they should be treated or hospitalized. So we have to search for hidden clues about their behavior, outfit, and so on. So one of the helps which we have is when we are looking to their eyes, as the eye is sometimes called a window to the soul, and we're trying to detect psychiatric disorders as early as we can, as the earlier diagnosis is established, then the proper treatment is also established, and the patient have better prognosis, so we're preventing the chronification and pharmacoresistance of the disorders. So some eye disorders can also lead to psychiatric symptoms, and one of the major challenge in medicine and also in psychiatry is to search for biomarkers. So let's start with the ophthalmologic presentation of the psychiatric disorders. So there are lots of organic disorders with various psychiatric presentation, but some of them can have also neuro-ophthalmologic findings. Some of them are more specific, like Wilson's disease with the Kaiser-Fleischer ring, or endocrinopathies with a thyroid ophthalmopathy, or neurosyphilis with Auger-Robertson pupils, but there are lots of more that have their own eye presentation, and that's the same in neoplasm, paraneoplastic disorders, or oncological problems. It depends on the localization of the disease. So I chose the Alzheimer's disease as this is probably the most studied organic disease with lots of degenerative changes in a brain structures, like cortical brain atrophy, like hippocampal atrophy, ventricular enlargement, and lots of others. But you could see also lots of degenerative changes in the brain, problems with visual functions, tear functions, and others. And there are some biomarkers which have been studied, like retinal and architectural alterations. This can be very important in finding of patients with preclinical Alzheimer's disease, and also abnormal pupil reactions, which can be present in this kind of patients. Schizophrenia is probably one of the most studied diseases in psychiatry, as we still doesn't know the exact etiology yet. Patients with schizophrenia, usually in psychotic phase, have typical saccharine eye movements dysfunction, probably connected with prefrontal cortical dysfunction, which is also connected with negative signs of schizophrenia. They can have staring or suspicious look in patients with paranoid delusions, or looking at one place, or rapid changes of sight in patients with visual hallucinations. We also have lots of structural and functional abnormalities, problems with visual processing, disturbed horizontal eye movements, which is also typical for relatives of the patients with schizophrenia. And we can find also the retinal nerve fiber layer thinning, which is not specific only for schizophrenia, but also for bipolar affective disorder, weaker retinal photoreceptor response to light, which can be found also in ultra-high-risk patients. Ultra-high-risk patients are the patients which are usually relatives of the patients with schizophrenia, which doesn't have to have symptoms, but they are at higher risk to convert to psychosis or schizophrenia-related disorders. And we can find also thinner retina with wider small veins. So this is electroretinography, which you're probably more familiar with than me, which measures the retina's response to light, non-invasive method, which is really important. Depression is present in about 10 to 20% of the population. It can present with sad eyes, poor eye contact, no makeup, as the patients with depression usually doesn't care about their outlook or outfit. Vertigo fault is one of the typical signs of melancholic or severe depression. You can see on the picture. It was discovered by or described by Vergut, which was a Swiss neurologist, but it's not very common, as I saw maybe 2 or 3 times in my clinical practice. Biomarkers which were studied are connected with the dry eye, which is also connected with anxiety disorders, and increased rapid eye movement density as a EEG sleep biomarker. Mania is the opposite of depression, with its happy or angry eyes. It depends if it's euphoric or dysphoric mania, staring or scanning. I saw many women with very colorful makeup, which is typical for manic patients. There is no single biomarker for mania, but there are biomarker studies for bipolar affective disorder. As I already said, the retinal nerve fiber layer thinning and the saccadic eye movements abnormalities. And there is a correlation found in vergence disturbances and saccadic intrusions. Anxiety is probably the most common psychiatric problem in about 40% of the population. It can be connected with fear eyes, avoiding of eye contact, light sensitivity, lots of others. PTSD is post-traumatic stress disorder, which is typical with its flashbacks. Flashback is a daydreaming or nightmare about originally associated trauma or traumatic event, and it can occur for months or years. Biomarkers which were studied are connected with pupil dilatation, eye movements, and fixation disturbances, and others. Intoxication with psychoactive substances, or repeated intoxication with psychoactive substances, is another big group of psychiatric problems. Opiates can lead to optic neuropathy. Hallucinations can be connected nearly with all the psychoactive substances. And again, we can see flashbacks. These are different flashbacks than in PTSD. These are connected with the drug use, usually marijuana or LSD. It can occur months after using of drugs, and usually presented with psychotic signs or symptoms, so hallucinations, delusions, depersonalization, and so on. This is a typical sign of intoxication with opiates, meiosis, with psychostimulants, mydriasis, and red eye, which is connected with intoxication with cannabinoids or alcohol. And we have a big group of non-organic or functional symptoms, which are connected usually with conversion or facultative disorder. We have to exclude always the organic factors, and these patients have usually positive history of emotional traumatic stressor or stressors. It can affect the afferent nervous system or afferent or efferent nervous system, eyelid position and function, and also corneal and facial sensation, and lots of others. We'll continue with a psychiatric presentation of ophthalmologic disorders. I just chose a few of them. So there can be a complication of there can be complications of eye surgery. I chose denial of the blindness, which can be also connected with psychotic signs. It is sometimes hard to distinguish the visual hallucination in blind patient, but it's possible. Black patch psychosis was described in 1950s after cataract surgery when both eyes were bandaged and the patient could experience visual hallucinations or paranoid or grandiose delusions. And post-operative confusion can be a really common post-operative problem. So visual hallucinations can be elementary, complex, or special types like micro or macropsia. It can lead. It can mean that there is a problem in the eye, like irritative phenomena of visual passages, or in the brain, or eye structures or brain structures, damage or ischemia of retina, ischemia of occipital pulse, or lots of others, like in temporal or occipital lobes of the brain. And Charles Bonnet syndrome is a specific type of pseudo-hallucination in older people. Pseudo-hallucination means that the patients are fully aware that they have unreal perception. It is usually visual, and the patient doesn't have any cognitive impairment. It is usually connected with a vision loss. We'll continue with a big group of the problem, which is called the adverse events of psychiatric medication. I chose the ocular one, which can be due to overdosage, side effects, hypersensitivity, idiosyncratic reaction, or intolerance. There can be categories due to disturbance of eye structure or functions, but I chose rather disturbances by the category of psychoactive or pharmacology, by pharmacology. So typical antipsychotics are connected with a typical sign of extrapyramidal syndrome, which can be also connected with the eye problem, which is really rare, but it can occur, and it's very unpleasant for the patients with schizophrenia. This is called or psychosis. This is called the ocular gyrate crisis, which is prolonged involuntary upward deviation of the eyes, which is usually bilateral. It can be connected also with deposited in lens, retina, and others. Atypicals are usually connected with glaucoma, accommodation problems, and others. Antidepressants, usually SSRIs and SNRIs, can lead to mydriasis, or SNRIs or NDRIs to angle closure, glaucoma, or blurred vision. Mood stabilizers are connected with double vision or accommodation problems. Lithium can lead to exophthalmos, as it can affect the thyroid gland. And others like benzos or hypnotics leads to visual problems, double vision. Antidementia, nootropics can lead to hallucinations, and psychostimulants to mydriasis and blurred vision. There is a possibility also to use the eye as a treatment of the mental disorders. There has been a psychotherapeutic method established by Shapiro in 1989, which is called eye movement desensitization and reprocessing, which is a psychotherapy method developed for treatment of post-traumatic stress disorder, but its indication is widening also to anxiety and phobic disorders. The original traumatic event is reprocessed to adaptive information and functioning with using of side-to-side eye movements or hand tapping, and it should weaken the power of the previous traumatic event. So for the conclusion, I want to say that psychiatric disorders can have a really important eye presentation, which can help us to search for the hidden clues, to detect psychiatric disorders as early as we can, and try to search for biomarkers. Eye disorders can be also connected with psychiatric symptoms or can have psychiatric presentation, and we have to keep in mind that there can be lots of ocular adverse events from psychiatric medications. So I think that it is very important to cooperate between psychiatrists and ophthalmologists. Thank you very much for your attention.
Thank you very much for a great presentation. It's like just wow. Now I would like to tell you something from my point of view as an ophthalmologist. So, what to say? Ophthalmology versus psychiatry. Of course, an ophthalmologist also should be able to recognize signs and symptoms of some psychiatric disorders. Of course, many patients have psychiatric disorders, and maybe we can recognize them as first, but we have to have enough time for the patient in the ambulance. Many of the drugs used in psychiatry can also cause ophthalmologic side effects. So we can identify subtle toxic effects of psychiatric therapies on the visual system. The patient with psychogenic complaint involving visual dysfunction may present with visual acuity or visual field loss or hallucinations, and ocular motility disorders or pupillary disturbances, which we can see. Of course, the change of eyelid position and function, and also corneal and facial sensations. So an ophthalmologist can also demonstrate the integrity of the visual system. The psychotropic agents can affect many eye structures. There are many drugs which are typical that they have side effects, so we have to really ask a patient with an history of some psychiatric disease about what medicaments he is using. So the antidepressants can cause mydriasis, which can cause also an angle closure glaucoma. Of course, another very bad disease is the dry eye disease or ocular surface disease, which can also have an effect of the quality of life of the patient, and ocular dystonia, optic neuropathy. We have to do a complete ophthalmic examination for patients to be started on antidepressants. It's very important for us. Also, the phenothiazines can have, especially in high doses, in patients who are really blind, can worsen, for example, retinitis pigmentosa, which is a really severe disease on itself. And if the patient has also phenothiazine among other therapy, because his psychic style of life is very bad, then we can also worsen the retinitis pigmentosa. Of course, we have to be extremely careful about acute angle closure glaucoma, because patients with occludable angles are at a very big risk. It can cause irreversible damage. The patient can gain transient mydriasis. He can have a closure of the iridocorneal angle, and these are the medications that can cause all these problems. Cataract is another adverse event of your therapy. Of course, we are very happy that we can cure a cataract with a very elegant surgery. So this is not such a big problem, but working, it stopped. Okay, my take-home message is that psychiatrists, ophthalmologists, and patients must be informed on side effects of each medication. Of course, it can be very difficult maybe to communicate with a psychiatric patient for us as an ophthalmologist, because the patient can be worried about his disease and all the side effects, so we need your help at this point of view, and we have to